Thank you for joining this channel. I know everybody's freaking out to worry about the next generation. This is my companion for you. You have to change the way you study and how you go about looking at diagnosis. The way they're presenting the cases, they want you to make diagnosis. But the best way for you is to focus on signs and symptoms. When you're reading and going about studying, pay attention to signs and symptoms. This is a question. I made it up, but it's classic. We see it all the time, and I'll walk you through it, how to solve these questions. Um, you have to read it, pay attention to the buzzwords, and then come up with the diagnosis, and you manage the patient. What is the scenario? Patient, 17-year-old, is in the emergency room, okay? We have a 17-year-old female present to the emergency room with complaint of what? Right lower quadrant pain, right? The pain started at the umbilicus and it migrated to the right lower quadrant pain. The patient report of what? What are the complaints? This complaint, nausea, anorexia. He does not want to eat. He feels like chills. He want to vomit. The pain is worse with movement. Whenever he moves, he has pain. He's never had any surgery before. His last menstrual period was 5 weeks ago, so she's late. And also report of spotting. There's blood in the vagina. Past medical history, none. No surgery, but no social history. No allergies. What is the general appearance of the patient? You look pale and anxious. What are the vitals? His temperature is 102. His tachycardic. Blood pressure 90/80. And then SATs 99% roommate. On exams, what do you see? A right lower quadrant pain with guarding and rebound tenderness. Y count of 14,000 and what? H&H is 930. What have you seen? Let me summarize it for you. You summarize it. I have a female who is 17-year-old. He has right lower quadrant pain that started from the periumbilical. Has nausea, vomit, chills, vitals, and has vaginal spotting. She has not had a menses 5 weeks ago. That's the last time she had a menses, so she's late. She's febrile. The blood pressure is low. She's tachycardic. Exam, she looked pale. And she has rebound tendons. What should be going on at the back of your mind? First, a 15, 17-year-old who is late, has right lower quadrant pain. You worry about ectopic pregnancy no matter what. At the same time, you say, oh, right lower quadrant pain. Pain starts at the belly button, then it go to the right. It's classic for the appendicitis. The appendix is always on the right. It starts from the belly button and go to the right because patient has fever, tachycardia, and he has rebound tenderness on the right side. This is wrong. Therefore, what do you think? We have a condition that we got to come up with the differential diagnosis. Right lower quadrant pain, fever, nausea, vomit, I think is appendicitis. Right lower quadrant pain on a female patient who is 5 weeks late from pregnancy, menses, it may be ectopic pregnancy. Those are the two top information you should put in your head. And you look at the question they're asking you. I try to make it easy for you, okay, so that you can see the way they can take you to. Which of the following is consistent with the diagnosis indicated below? I give you information, I mix them so that you can figure out. You have appendicitis, ectopic pregnancy. Y count of 14,000. Is it consistent with appendicitis or ectopic pregnancy? It's no brainer. It's infection, appendicitis. Systolic blood pressure, hypotension. Is it consistent with appendicitis or ectopic pregnancy? No, unless they're in septic shock and that septic shock will take a while, it's not appendicitis. It has to be ectopic pregnancy. They're bleeding. Tachycardia, if you have infection, you have tachycardia. If you're bleeding, you have tachycardia. Temperature 102. What do you think? Itis, infection. Right lower quadrant pain. They both can have right lower quadrant pain. Vaginal subspotting. I don't think appendicitis will have it, so it's ectopic pregnancy. They look pale. Somebody is bleeding to be pale. This. And this is how you go about it. Based on what you think is the problem, then you break it down like that. Next, what did you say? I did not let you go just like that. I want to make sure you understand what is going on. So they get a CT scan. It was ordered, and it showed inflamed, thickened appendix. You got to be reading things that usually you ignore it. Inflamed, thickened appendix, about 1.2 centimeters, and small peri-appendiceal fluid. I'm a physician, so that's why I know how to write these questions. And you can see this is consistent with what? Appendicitis. Appendix is thickened, it's inflamed, it's bigger than normal, it has small fluid there. It's not perforated, but this is appendicitis. And I want to let you think. So I ask you, which of the following is indicated? What is indicated? If patient has appendicitis, do you put an NG tube in? No, it does not have obstruction, so it's not indicated. Do you need antibiotic? Yes, of course. Do you want to feed the patient? No. Therefore, it has to be MPO. For every GI pathology, there's 4 or 5 things you should know. MPO, IV fluid, antibiotic, NG tube, and pain management. Depending on which one, you have to classify which one. All of them need all the 5. IV fluid, yes, give him some IV fluid. Pregnancy test, think about it. She's a female. She's 5 weeks away. We know she has appendicitis. We still have to do pregnancy tests before we take them to surgery so that we make sure we confirm she's not pregnant. So this patient needs pregnancy test. Pain management, yes. And that is how you do these questions. If you have a problem, come to my channel. You'll be more than prepared. I'll teach you like I do. I take care of patient as a physician. It's the way we do. Analyze it and you will understand it. Okay? So I have another question. Like I said, use this as your companion and go back to it and keep on thinking about the way I'm analyzing the question. Okay. Same question in a different form. A 56-year-old female in a ED emergency room with facial droop. Now she's drooping. Okay. A 56-year-old female present to the emergency room with right facial droop, drilling and unable to close the right eyes. There's a loss of taste on the right side of the tongue. Patient had an upper respiratory infection 3 weeks ago. She has obesity, hypertension, diabetes, hyperlipidemia, OSA. No surgery, stopped smoking 2 weeks ago. What? No allergies. Vitals are normal. Okay. Now, neuro exams, people equal reactive, okay, bilaterally. There's right facial droop, left and upper extremities. Look at it, 5 out of 5. She's AO times 3. There's a right nasolabial fold flat. Pay attention to signs and symptoms now. Signs and symptoms for every diagnosis. Think about it. 56 years old patient has a facial droop, right? Unable to close their eyes. And they're drilling on that side. It sounds like stroke, right? She has loss of taste. Okay? But there's no aphasia. I did not say that she has trouble talking. This patient's symptoms happened after upper respiratory infection 3 weeks ago. Every signs and symptoms on the right side. On your physical exams, the left and upper extremities, their arms, the body has 5 out of 5 strength. That means there's no weakness in the lower extremities or anything like that in the upper extremity. And the patient is alert oriented times 3. And the right nasolabial fold is flat because of drooping. because of drooping. What do you think? This is Bell palsy. It's not stroke. It's not ischemic stroke. And that's how they will present this kind of case to make you think. Therefore, I've made the diagnosis. Let we see what do we have here. Drug 2 teaching and 2 treatment, the next you anticipate based on the primary diagnosis. So what is your primary diagnosis? Is it stroke? Is it transit ischemic stroke? Is it Bell palsy or trigeminal neuralgia? It's Bell palsy. Trigeminal neuralgia, they have shooting pain in your face. Those who have weakness of the lower extremities and have some aphasia. This is transit. You will have like they describe curtain falling on the eyes. Now you know it's Bell palsy. Usually happen after viral infection. That will resolve on its own. It takes some months, 6 months or 3 months to go away. The best treatment for this, we give them sometimes steroid to help with the inflammation and treat the viral infection. Carbamazepine is used for trigeminal neuralgia. And Atiplas is when you have stroke. So this patient does not have stroke. How do you teach them? Eat a soft diet, wear a patch at night, wear what? Glasses during the day, chew on the unaffected side. So this is wrong. Avoid odd food is for trigeminal neuralgia. You don't do that. So, and let them chew on the unaffected side. That will help with the drooling and everything will get better. So soft diet, wear a patch, Bell palsy, steroid, antiviral. This is what the test is going to be. Remember, don't freak out. Not every portion of the test is like that. There will be like 6 or something cases. Okay, that will be the next generation. That means at least 75% of your test is still going to be the old one. So you still have to know how to do select and apply. You still have to know how to do your pharmacology. You still have to worry about the old one. So pay attention, study, and try to get your content. And when you're ready, take it. Don't rush. Okay. Steady, get your content. When you see a next generation question, flip it and say, I'm looking for signs and symptoms to make a diagnosis. As you learn, do both sides and you will be fine. Adapt NCLEX, get your back. Take care of yourself and have a good day.